And just to answer about the 3D and imaging and all, so it's going to come. It's already in the pipeline. The biggest lab working on AI is the Mahmood Lab in the US, and they've got a lot of funding about 3D imaging, be it histopathology, image, or radiology. So what they do, like in case of pathology, at least when we see it's a section, it's a 2D section, but see it's just 1% or 2% of the entire tissue which gets sampled. So now they are coming up with technologies which will replicate that biopsy in a virtual way, stain it in a virtual way, so that the entire biopsy gets what you call documented as multiple tiles, maybe 256 cross 256 tiles, and the AI model will look each tile separately, and because the images are so heavy, it converts the image to a text. So it will be maybe like a metadata analysis. So it will be in kilobytes, and that data is used for predicting, diagnosing, and prognostication. At least in pathology, the 3D is going to come.
So that tells us also why it is so difficult to sell tech. You know, we have glitches and glitches.
So in pathology and radiology, the AI has penetrated a lot now. So in pathology, there are a lot of revolutions. The recent one was the molecular pathology, and now the next is the AI and computational. This is how the journey of a glass slide happens, and the pathologist sees the glass slide for diagnosis. Now we have an added step. The first step for using any AI model in pathology is to scan it and make a whole slide image. So there's a lot of advantages of going digital, that you can report it from anywhere and use these images for AI models. So there's a lot of opportunities, but there are challenges in terms of storage, transport, cost. Now what happens, like only generating a digital slide doesn't help. You have to use it in a setting which will help the larger masses. So when it comes to AI models help in diagnostic, theranostics, predictive, prognostic, a single glass slide without doing any other additional test. An AI model can help you doing all these things. It has to be a specific question and a good refined data to do it. So many of us have seen reports of, say, neuroendocrine tumor, grade 1, grade 2, grade 3. It's all based on the MIB1 index and the mitosis. It's a very subjective thing, like a human counting a mitosis or a MIB1 or a Ki67, and a 3% becomes grade 1 and a 4 becomes grade 2. So here we can use an AI model. This is a QPath software. If you use an AI model, it will highlight the positive cells. It will give you a score that these many out of this many were positive, and it's an objective method. And a grade 1 neuroendocrine may go for observation, and a grade 2 may require intervention. So that's how critical a pathologist diagnosis is there. Identifying tumors, the patterns of the tumors, you can use a lot of AI models which can identify your tumors, how they are, the grade of tumors, like a squamous carcinoma. Many of us have been doing head neck. Identifying a pattern 5, it's a poor prognostic. An AI model can pick up how far it was. A pattern 5 has to be 1 millimeter away. Protein expression, like I said, breast cancer, without an HER2, ERPR and HER2, no medical oncologist is going to touch the patient. Now, if a IHC is taking 7 days, an AI model may require 2 minutes to predict whether the tumor was HER2 positive or HER2 negative, only on the basis of their H&E image using the computational power. An H&E image can predict a lot of things, like whether there's a tumor, or there's how to subtype the tumor, classification. Using a squamous carcinoma data can be used for any other sites which is also squamous, like a cervix cancer, so that the AI model has to be generalized. Lymph nodes metastasis, like I come from a cancer center, the Tarmamel Center, where we are dealing day in, day out with oncology, and major bulk is the lymph nodes in our trays. So missing out in the evening you're tired, you might miss out a small note. So all these things are there possible, and in our lab we are working on it. There may be scenarios like two patients having a stage 2 age matched disease, but they behave differently. So it is the AI which can predict the pattern recognition, like this was different from in one case than the other, and it may help for escalation or de-escalation of the therapy. So a lot of things have been going on, the tumor infiltrating lymphocytes, the stroma, everything predicts. So I'll talk about what we are doing in our lab at Mumbai, the TMC Mumbai. So annotations of the AI model, the first requirement is to how to annotate the data. So we all use a Google Capture to log in anything, like be it the bridges, the water pumps and what all. We have developed our own pathology-based Google Capture, where for login, a pathologist has to identify the annotations correctly, then only he can log in. So that helps us to give us an annotated data. So without asking a pathologist to do something, they are doing it. This is one of the paper which we did. It's about the ERPR using HNE, and we had published this in JPath Inform. It had a very good accuracy of over 85%, and as we say, an AUC of more than 85% in artificial intelligence is as close to as human ones, because mining the human error. So like Dr. Sombe said, that acceptance is not there. So this was one of the paper. On HNE, we did a BRAF mutation in thyroid with a very good accuracy, but still it has not been implemented for the masses because that acceptance is still not had come. We have started this doing in our setup. Again, similar paper we did on EGFR mutations using HNE. Again, real-time diagnosis on the EGFR using a HNE slide. Otherwise, a PCR will require, say, 7 days for the report. Similarly, a deep learn, this was a paper done by my colleague Abhishek with myself and Rajiv in that, where using the HNE images, we could predict that this patient will have a brain mets using us in future in a non-small cell lung cancer. And this was well accepted, and it had a good prognosis and a good acceptance. I had presented last year at the ACDP Budapest, where an HNE image, we were predicting whether this had an HPV positive or HPV negative, because human papilloma virus in head and neck has a prognostic significance. And if you see, it had almost a good sensitivity and specificity of almost of 95%. And it was compared with the gold standard, that is in situ hybridization. And we had a good concordance of 0.95%. Now, many slides have a lot of artifacts. So this is a validation, this is a quality control algorithm which we have developed in our center at Tata Memorial Hospital, which will tell you that this slide should not be submitted to the pathologist. Again, a lymph node metastasis, this I presented last year about predicting lymph node. Pan cancer, if you see the different specialties, thoracic, breast, GI, urology, and with a good positive predictive value of 0.95 and a recall of 0.86, that if I throw the same slide maybe after 2 months to the model, it has a good accuracy in identifying. So these are multiple things which we are doing across the pan. Lymph node metastasis, the AI is the model which we developed is actually highlighting, if you see, is a very small tumor sitting here. The AI in its heat map is identifying. It is like an assist to me that, okay, there's a MET, see it properly. The small MET, the AI model is picking up, quantifying it, how big it is, again, with a good predictive value. So that's all we have doing in our lab. So now, as I said, like I started on the first slide, I reach again to this last slide, that right now, we heard a lot of things that the AI is going to kill jobs, or it's a terror or something. It's an assisted tool. It will always assist you in what you are doing. And AI has been built by the data which you have provided. AI is not generating any data on its own. So it is the ground truth always lies with the doctors or the person who has given the data. So right now we are at this level, and we have to embrace and accept this. Otherwise, it's our loss and we will perish. So this was what we do in our lab at TMH with my team here, and with collaboration with DBT, Niti Aayog, and IIT Bombay is a close collaborator for us. So this was the crux with all the work which we are doing in TMH Mumbai.
So